The more severe the heart failure, the greater the prevalence of atrial fibrillation. The more persistent the atrial fibrillation, the greater the prevalence of heart failure. So over the next couple of minutes, we'll just talk about what is the current evidence of offering rhythm control therapy for patients with heart failure. So this coexists and each feeds on to the other. Atrial fibrillation worsens heart failure and heart failure worsens atrial fibrillation. And the primary therapy is pharmacological therapy, initially a rate control. And there is increasing evidence that rhythm control offers a significant benefit among patients with atrial fibrillation. All patients with heart failure would require optimal medical therapy in terms of GDMT and anticoagulation for stroke prevention. Early on, about 2 decades ago, the group from Bordeaux showed in a cohort of about 50 patients that if you take patients with heart failure, severe LV dysfunction, what you see on the y-axis is what you see on y-axis is the left ventricular ejection fraction. This is the duration. After catheter ablation, progressively there is an improvement in EF, reduction in both left ventricular end systolic and end diastolic volumes. And after this, several small studies in different centers were able to reproduce the results that if you achieve rhythm control, especially with catheter ablation, where sinus rhythm is restored, the EF improves significantly in a vast majority of these patients. Now, having said that, we have been used to giving medical therapy for most of our patients. We don't offer catheter ablation. They come to us with symptoms. There's a lady with heart failure, well managed on medical therapy, had atrial fibrillation, was started on amiodarone beta blocker, adequate anticoagulation, comes back with symptoms of palpitation and worsening symptoms of heart failure. Therefore, the dose of metoprolol was increased. And 2 days after the heart failure admission, she comes with this degree of a long pause and from frequent PVCs requiring a pacing. This happens in real life. Luckily, this patient, it happened within 2 days. But very often in clinical practice, when you escalate amiodarone, this patient is lost for follow-up. It is always the successful story that the patient who has survived who comes to us, the ones who had polymorphic VT like this will never come back to tell the story. And this is the reason why, even though we offer very effective therapies to achieve rhythm control, at a particular dosage it's ineffective and we escalate the therapy. Remember, in patients with heart failure, there is a very narrow therapeutic window. And patients, as we escalate therapy to achieve rhythm control, it's a temporary success. Long term, we lose these patients due to ventricular arrhythmias in these patients. Over years, we have also realized we should thank Dr. Zogby to highlight this entity, where a significant proportion of patients with heart failure develop mitral regurgitation, especially if it's due to atrial fibrillation. They significantly improve if you control the atrial fibrillation. So please remember, if you have a person with central jet MRTR, which is not holosystolic, please reassess the mitral regurgitation and tricuspid regurgitation before offering some definitive therapy for valvular regurgitation. Atrial component of functional mitral regurgitation is a realistic problem, and this can also be seen in some patients with tachycardiomyopathy when there is annular dilatation. Functional mitral regurgitation due to ventricular mechanisms also do coexist. And a couple of years ago, there was a seminal study which came out realizing the limitations of pharmacological therapy. They took a cohort of patients, about 180 patients, randomized to catheter ablations versus medical therapy. These are patients with persistent atrial fibrillation who have class 3 heart failure. And over a period of about 5 years of follow-up, there was a significant survival benefit among patients who have been offered catheter ablation. Now, looking at all the drug trials, all the trials we are talking about, 0.015, there is a 45% absolute risk reduction of death from any cause when they are randomized to ablation compared to medical therapy. This is among patients with heart failure with reduced ejection fraction. There is both cardiovascular death, total mortality, heart failure hospitalization. All the indices point in one direction, saying that pharmacological therapy, even though it may be lull you into a sense of complacence that you have achieved sinus rhythm, in long term, it increases mortality. Now, the Germans went one step ahead and said, if this is happening in stable heart failure, can we take patients who are listed for transplant? They went to a heart failure unit, took up patients who have been listed for LVAD or transplant, and took patients who are in simple atrial fibrillation, not very fast rates of 90 to 100. If they have persistent atrial fibrillation, they offered catheter ablation versus medical therapy, and at the end of 2 to 3 years, it's clearly seen that ablation group, restoring sinus rhythm, the mortality, survival is much better in this patient. And what we are seeing is in these patients, you can delist them from transplant. After this group, several of them were delisted. They didn't need LVAD. They didn't need a transplant. And the mortality significantly came down after restoring sinus rhythm. So before mechanical therapies, ECMO, all these things, if a patient is in AFib, please call your electrophysiologist who is with your institution. Go all the way out to restore sinus rhythm. What has become more attractive over the last couple of years is instead of doing a point-by-point ablation, several one-shot devices are safe and effective in terms of either using cryo energy or pulse field energy. These things are going to make it a lot more simpler. And in addition, the use of contact force has improved both the efficacy and the safety of catheter ablation close to about 70 to 80% in several of these patients. And one-shot devices offer, sometimes even in persistent atrial fibrillation, you get results like this, termination of atrial fibrillation and restoring sinus rhythm. So looking at the data, whom would you recommend, who's likely to benefit from non-pharmacological therapy? Patients with, there's clear evidence that heart failure with low EF, not paroxysmal atrial fibrillation, but persistent atrial fibrillation, they develop, they have significant benefit by restoring sinus rhythm. The other group is a patient who is doing very well, but when they develop AFib, they develop significant ST depression, they go into pulmonary edema. Those are the other patients you may think of offering a catheter ablation for these patients. But it's not always ablation. You need to take care of the comorbidities, and optimal medical therapy has been shown by elegant studies from Melbourne, Australia, Adelaide group, which showed a significant reduction in events when these patients are offered GLP-1 agonists or weight reduction by whatever methods you have. These patients have significant benefit. So in summary, Chairman, ladies and gentlemen, optimal medical therapy and risk factor control is extremely important to prevent atrial fibrillation. But if there is an onset of atrial fibrillation which is persistent, try to achieve rhythm control initially by cardioversion, and if it fails, the AFib is persistent, catheter. And that is the reason several therapies, the diastole is very blunted. What this original paper, Mark Myers came and showed was, in contrast to heart failure with reduced ejection fraction, if you increase the heart rate, the dV by dt in diastole actually improves. So the lusiotropy, that is isovolumic relaxation, which has a suction effect, improves by reducing the calcium current in diastole when you increase the heart rate. And this was the original paper which was done based on animal models, and later on, emboldened by the results, these guys went on to a randomized clinical trial, including 50 patients in each arm, 52 and 48, and they showed that when you have accelerated pacing, these patients did better on follow-up compared to conventional no pacing group. This was a randomized control trial. So we accidentally stumbled on this area by a very frustrating patient who had not exactly HFpEF, but a non-ischemic cardiomyopathy, very symptomatic recurrent atrial fibrillation, didn't respond to multiple antiarrhythmic therapy, repeated cardioversion. Whenever this patient is sinus rhythm, she is in class 1 to 2. When she goes into AFib or flutter, She becomes very sick. Within 2-3 days, she will come with severe heart failure. She has an ESC risk score of 5%, and therefore she had an indication for a dual chamber ICD, and this was the recurrent flutter that was going on. And as you can see, the P wave is broad, the amplitude is less. You can hardly see a P wave in lead 1. These kind of findings does suggest that this patient had an intra-atrial conduction delay. But we were not sure. So we took this patient to the echo lab and look at the mitral A wave and tricuspid A wave. There is almost 100 millisecond delay between the tricuspid A wave and mitral A wave, suggesting there is a significant atrial delay in this patient. So we had this experience of doing surgical Bachman bundle pacing several years ago when we were in care surgically, and so we just took the same kind of experience to percutaneous and catheter-based therapy, where we positioned this in the area of left bundle, and you could see a significant narrowing and peaking of the P wave, and it's about 4 years this patient hasn't had an atrial flutter or fibrillation. If left bundle branch block correction can reduce the VT, the same way intraatrial block correction will reduce the atrial flutter. And this is the final P wave we got. You can see off pacing the diastolic function E by E prime was 22, and on pacing with an increased rate of 70, there is a significant improvement in DT as well as by E prime in the same patient. Actually, several of the unsung heroes in medicine are the foundational fathers. This is Bayes de Luna, who described this entity several years ago, calling as an intraatrial block as Bayes syndrome, and he had ECG characteristics where the ECG becomes the activation wavefront goes downward from and then goes up. So this leads to prolongation of P wave, notching of P wave, and inverted P wave in lead 3, differing grades of intraatrial block. And hemodynamic consequences of intraatrial block is that the A wave becomes very truncated and very late, and this becomes more important in HFpEF patients. So what we thought was, if I accelerate the atrial rate by atrial pacing, I introduce, it's like RV pacing in the ventricle. When you increase the atrial pacing by right atrial appendage pacing, you actually increase the P wave duration. The rate increases, but the P wave duration will paradoxically worsen. So in olden era, about 2 decades ago, people did biatrial pacing. It's very cumbersome. You can shorten the P wave, but it didn't show great benefit. And again, this author, Bachman, showed that if you can capture the Bachman bundle, you can significantly reduce the intraatrial delay in these patients. And that is marked by a significant reduction in P wave duration compared to sinus rhythm, the Bachman bundle, significant reduction in P wave duration. But look at what happens in right atrial appendage pacing. It significantly increases the P wave duration. So you want to increase the heart rate for a improvement in diastolic function without compromising on the P wave duration, and the best place seems to be the Bachman bundle. And that is what Mark Meyer showed in MyPace trial, maintaining a heart rate of about 80 to 85 with optimization of the AV delay significantly improved their NT-proBNP as well as their heart failure symptoms. We have been using a screw-in lead at this site by the pre-shaped, the conventional tools we use for conduction system pacing. We come from the SVC, rotate and position it towards the medial, and RA appendage is anterior, whereas Bachman bundle is posterior. You need to rotate and have the lead facing the posterior aspect, and I don't know whether it plays. Animation is not required for this. So we have a temporarily, if you take it like a clock, it's around 3 o'clock position here, and before we screw it in, we measure the P wave amplitude. Usually, typically, you'll have a split P wave here, electrogram here. And that is, we call it as a Bachmann potential mainly because it indicates two layers of muscle fiber, one on the endocardium, one on the epicardium, and you record both these things as you can see fragmented potential. When you pace, the P wave becomes tall, upright, and narrow. Generally, about 20 millisecond reduction in P wave duration is considered to be a satisfactory site. And mapping the Bachmann bundle and seeing a split potential helps us to improve the success rate. This lead, the only problem is because it's a new site, Muthaiya looked at these patients over follow-up for 1 year. The lead parameters are very stable, and prospectively we did this on patients with non-obstructive cardiomyopathy, and we can see, in the interest of time, there are approximately 40 patients, and we can see over a period of time, the P wave duration significantly came down to about from baseline of 160 to 116, and you can see their NT-proBNP dropped over a period on follow-up. E by E prime improved, and these patients have significant benefit on follow-up. So we are now expanding this to a sponsored study. If you have a person with chronotropic incompetence and HFpEF who has got significant symptoms, these patients, we get a free device for them, 1:1 randomization with Bachmann bundle basing on versus RA pacing to dissect whether it's the rate alone or whether the site is also important to improve the outcome in these patients. But there are several unanswered questions. Again, HFpEF is not a single entity. A clinician should evaluate to exclude other conditions like amyloid and other conditions which can cause HFpEF, and then only this is likely to be useful in our cohort of sick patients. Thank you very much for the patient listening, and again, this is what, all work is done by Muthaiya, my colleague. Thank you.